lots here from lots of different types of organisations. We've got a lot of spread from people through NHS organisations, but also some of our charity partners and other independent organisations. So it's lovely to see so many of you joining us from different organisations. I think we've pretty much got most people in from the lobby now, so we will get started. Welcome everybody. My name is Emily Evans. I'm the Deputy Chief Exec at Everyturn, and it's my absolute pleasure to host you on today's webinar. This is the second webinar in our second series, all about the 10-year plan. And this series we're focused on illness to prevention. So this is the focus of the 3 webinars that we've got in this series. And today we're going to be focusing on the safe havens that we deliver at Everyturn. We're really proud of our safe havens, so it's lovely to get this opportunity to share a little bit around the model of delivery. And we've got some great presenters here today who work within our safe havens who are going to be talking you through that. Our Q&A function, the chat box, is open, so as our presenters are going through, please feel free to pop any questions in there. We've had amazing engagement in our previous webinars, and it's really been really lovely to see lots of questions come through and be able to take that. So there's plenty of time at the end for you to ask questions and for the speakers today to answer them. Just a little bit of housekeeping before we get going. Please, if you can keep your microphones muted throughout the session today. If you can keep your camera off as well, unless you're presenting, that's just really helpful in terms of the quality of the presentation. We have got a case study or 2 within the session today, so just so you're aware, we have got consent from those case studies, people in those case studies, to share their stories. And as I said, the chat function's open, so thank you to everyone who's popped in where you've come from today. Feel free, like I said, to drop any questions as the speakers are talking through, and we'll have plenty of time for that at the end. As you can see, the session is recorded, so if you haven't made any of our previous webinars, you will find the recordings on our website, so do feel free to pop on there and have a look at the recordings. But now I'll hand you in to Sam, who's going to start us off today.
Thanks, Emily. Hi, everyone. I know Emily's already said it, but thanks very much for joining us. I am Sam. I am Senior Development Manager here at Everyturn. We have got lots on our agenda today, so I will go straight into it. Today, we will talk about our safe havens, so they're a key part of our wider crisis support models. In a few minutes, we'll obviously hear from our operational colleagues, James and Jack. We'll also hear from Rebecca, who's one of our system partners, and we'll talk through the safe havens in terms of how they function operationally and what we've learned as well. But before we go into that, I'm just going to talk a little bit about Everyturn for anyone who's not familiar with us or anybody who's not attended our previous webinars. So we're founded in 1986. It is our 40th birthday this year. We started as a single care home in the Northeast. We have expanded since then and deliver clinical and non-clinical mental health services nationally. We offer specialist nursing services, children and young people services, community and crisis services, and NHS talking therapies. This is some of our models. They vary in terms of intensity and a model within the actual model in itself. We have community rehab models. We have the 24-hour mental health nursing services. We also have step-down housing services, crisis services, which the safe havens are a part of that we'll talk about today, NHS talking therapies, and our community and wellbeing services. Before my colleagues go into the operational detail, I'll just talk about our organisation and the governance for a few minutes. This is really important within all our models and works across all the services that we have in Everyturn. If you've been to one of our webinars before, you've probably heard myself or my colleagues talk about this. I have really strong clinical governance frameworks in the organisation. We have board level oversight with subcommittees. We have an exec leadership team and a senior leadership team. Within that, we have really strong clinical presence, both within the leadership teams and throughout the organisation. We have access to registered mental health nurses from our national and local teams and on-call clinical support across the organisation 7 days a week. We've also implemented a recently clinical leadership and oversight for our non-clinical teams with a clinical lead across our crisis services. Lived experience is central to all our models, and lived experience is involved from the design of our services, but also the review of our services, improvement recommendations, and within the infrastructure of the teams themselves. We have really strong digital infrastructure as well. We've got an NHS compliant digital ecosystem. We use NHS recording systems like Rio and PCMIS, which means we can integrate with our NHS partners and their systems as well. We have Tableau dashboards, which allow us to look at real-time data and analyse this. And we've also led in the development of a single patient record with NHS Trust and partners for our neighbourhood mental health site, Hope Haven, which we will have our next session on. I'm sure Emily will touch on that in the end. We've got really strong quality assurance and our learning organisation with PSERF aligned. We've got really strong safeguarding infrastructure, and our clinical director acts as our safeguarding lead. We've got monthly quality and safety forums, and we've got really strong business continuity and service resilience. So got really 100% service continuity across the organisation with no historical downtime, and that means that the people we support always get the support when they expect it and when they need it. So I've got some pictures of our North East safe havens, and I'll hand you over to my colleague James, who will go through a bit of an overview.
Hi Sam, that's great. Thanks. Hi everyone, my name is James Nichol. I'm the service manager for our crisis services and safe havens across the North Eastern Cumbria. I'm here today to give an overview of our safe havens. I'm going to talk about what makes them impactful, who uses them, the importance of involving lived experience, and tell you about the demand and patterns we've seen in our services. Then I'm going to hand you to Jack, who's going to talk in some more detail about the safe haven model. Next slide, please. So a safe haven is a non-clinical open access space for people experiencing emotional distress or who are feeling overwhelmed, particularly outside of typical 9 to 5 service times. It provides immediate, compassionate support every day of the year without the need for appointment. They are designed to reduce escalation to emergency services and to help people feel safe, heard and supported at the point of crisis. They are open access, so people can self-present, be signposted or supported to attend by a professional through another referral method. Support is immediate in the moment. There's no waiting list, and the person can walk into the safe haven, dial in or have a virtual appointment depending on their choice. Safe havens are for people experiencing mental health crisis or acute distress. People whose distress is driven by social factors such as poverty, housing instability or loneliness. Safe havens are for people who may not need secondary mental health thresholds, but still need urgent support. Safe havens aren't a replacement for emergency medical care where clinical intervention is required. Safe havens are needs-based. People seeking support will receive a warm welcome. Someone will listen to what's going on for them in the moment and take some notes. The mental health support worker will support the person through distress management techniques and crisis de-escalation. They will work together on a safety plan and talk about goals, and then they'll record this information on the patient management system Rio, as Sam's just described. This means that the person doesn't need to tell their story more than once, and that also helps us manage risk related to the person. During the support, a person's needs may be met, or they may come back for a short series of support perhaps. Through strong partnership working, we can also act as a front door to wider system, providing warm onward connections to other services as needed. In summary, a safe haven is an open access, non-clinical crisis support service offering immediate, compassionate help to people in mental health distress, helping people prevent escalation and connect to the right support at the right time. They focus on prevention, early intervention, reducing crisis, escalation and pressure on statutory services. Next slide, please. When Everyturn found out we were successful in the opportunity of delivering safe havens in the North East, we worked with the community and people with lived experience. As an example of that, we worked with Healthwatch and Launchpad in North Tyneside to design the model together. This was really helpful, but it's also important to point out here that it did take a long time in reaching mutual understanding of what the model needed to be. At first, some people wanting to access the service wanted things like palm trees, horses, and dartboards in the service at the start. We worked those things through together with commissioners and the groups to understand what the aim was and build what the service was commissioned to do, but also meet the needs of people who would be accessing our services. We held things like open forums and remained involved through the development with Launchpad and Health Watch leads being within the steering group and guiding everything we did. They supported with the model, the support offering and the team mix, as well as design and use of the space, name of the service and the referral processes. When we went through the recent retender process, people with lived experience who had accessed the service supported us in reviewing the provision we'd offered. We held focus groups and panels and also anonymous questionnaires to gather feedback. I was lucky enough in my role to meet with some people who supported in our safe havens with their journey, and I'll talk about that very soon. We also have people with lived experience within the team, including peer support workers. These workers add unique value by using lived experience to engage with people in ways traditional roles can't. In our last webinar, we heard from Cassidy, who was a team member within our safe havens. She talked to us about her journey from accessing services like this to supporting others in her role where she works as a mental health caseworker for Everyturn now. She also talked about the importance of this. Peer support work improves engagement, trust and recovery outcomes by using lived experience to connect with people. Next slide, please. Everyturn were the first provider of safe havens in the Northeast. Currently, we have 3 adult safe havens in the Northeast. We have the Bothy in Northumberland, the Anchorage in North Tyneside, and George Street Social in Newcastle. These services are open 7 days a week until 10 p.m. Everyturn also work as part of Hope Haven in Cumbria, and we have 1 adult safe haven as part of that model, which is open 7 days per week until midnight. For anyone joining us on Thursday's call, we'll be talking about that more then. We also have a children and young people safe haven in the Northeast, which opened in April 2026 in Newcastle and Gateshead, where we work in partnership with Children Northeast, and a children's crisis cafe, which is a drop-in in Wallsend at the Anchorage Safe Haven. All services are accessible right on the high street, where people can walk in, dial in, or access the support virtually. Our adult safe havens are open 365 days of the year. Next slide, please. We see a great demand in all of our services, helping people when they need it. On this slide, you'll see the number of people who have accessed support between January and March of this year. One theme is presentations around anxiety and suicidal thoughts. That tends to show up as immediate distress or crisis, but it often sits alongside other wider set of pressures. We also see housing instability and loneliness staying consistently high across all of our areas. Another key theme is food, fuel, and utility poverty. This is where partnerships add real value. For example, linking in with local authorities on housing pathways, or with community supports like food banks to help reduce immediate pressures while mental health support is put into place, or the stress of the crisis level reduces. We work with people on these practical goals and support in reducing repeat crisis. Next slide, please. You'll see here some impact in numbers, and as I said earlier, we see a huge demand on the safe havens. In my role, I'm lucky enough to work with so many amazing people who deliver amazing outcomes each day of the year. I'm also lucky enough to meet with people who've accessed our safe havens for support. What matters most is what happens when they walk through the door. So people told me that they're met by someone who listens, someone who takes their time, someone who doesn't judge, someone who doesn't rush to fix or diagnose them. Just someone who was there with them to de-escalate, to sit alongside them and to help them through that moment. A lot of people choose to come here specifically because many have had negative experiences elsewhere. Here they tell us they feel like a person again. They feel believed, they feel treated with kindness and respect, and that human connection makes a difference. The space itself supports that feeling. People describe it as warm, welcoming and homely, more like a living room than a service. The common colours, the local artwork, the overall feel of the space helps people breathe a little easier. For some people, just being there in that space is the first step in feeling okay again. But what really stayed with me is why people come here in the first place. They come because they need a compassionate ear, because other systems haven't worked for them previously, because they're lonely, overwhelmed, or trying to stop things from reaching breaking point. They come for connection and to feel less alone. And this is the part that really matters. For many people walking through that door, they don't have to carry everything on their own anymore. Having someone there on the day can be enough to steady someone when they feel like they're falling apart. Sometimes we're not the place where everything gets fixed, but very often we're the place where people feel safe enough to pause, and to be heard, and to keep going on. And for some people, knowing that someone was there at that exact moment is what's helped them get through one of the hardest days of their life. Before passing it to Jack, I'm now going to show you a short Safe Haven video of the Bothy in Northumberland. Thank you.
Welcome to the Northumberland Safe Haven, right here at the Bothy on Ashington High Street. We're open every day from 2 p.m. to 10 p.m, and we're here to offer emotional, social and practical support for anyone aged 18 or over who might be experiencing mental health crisis or distress. You don't need an appointment and you don't have to be from the area. You can just drop in when you need some support. When you arrive, our friendly team will welcome you and ask you some questions to make sure you and everyone else in the Safe Haven are safe before they start your one-to-one support. We'll get you settled with a comfy seat and a drink. We'll also ask you to fill in a short form so we can understand what you're hoping to get out of your visit. And if you'd like help with filling it out, we're right there with you. If you'd like some private time to talk, we can offer a one-to-one session where we'll help you work through what's going on, create a safety plan, and support you with your goals. If you'd rather stay in the shared space, that's okay too. We'll just check in now and then to make sure you're feeling safe. We'll work with you to manage how you're feeling and look at any practical things that might be affecting your mental health. We can help you with emotional support, difficult feelings, putting together a well-being plan, or connecting you with ongoing support in the community. If visiting the Safe Haven in person doesn't feel right for you, we also provide online appointments. You can find these on our website. At the end of your visit, your support worker will check in with how you're feeling and agree any next steps with you. You're free to leave whenever you choose, but our team will continue to support you until you feel your crisis has eased. We also have Safe Havens in Newcastle and North Tyneside. To find out more about how our Safe Havens can support you, visit www.everyturn.org/safe-haven. Welcome to the Northumberland.
Thank you very much, James. So I'm Jack Southern, the team manager within Everyturn's Crisis Services, and I manage the Anchorage, which is North Tyneside Safe Haven. I'm going to talk through how Safe Havens work in practice, covering the different access routes, our staffing model, the support we provide, and how we integrate with the wider systems, and then I'll finish with a short case study. So one of the key strengths of the Safe Haven model is how accessible and flexible it is. People can access the Safe Havens through a number of routes, and that includes walk-ins without the need for an appointment or referral, self-referral, which removes barriers for people who may be reluctant to engage with statutory services, police or ambulance services, where Safe Havens can be used as an alternative to emergency departments when appropriate, and professional referrals from partners such as crisis teams, primary care, social care, and VCSE organisations. This multi-route access is intentional, and Safe Havens are designed to meet people where they are, both literally and emotionally, and at the point they need support. We also offer a virtual Safe Haven appointments delivered via telephone or video call, and this is particularly important for people who might feel too anxious to attend in person, have mobility, transport or caring barriers, or simply feel safer engaging from home. Whether someone attends in person or virtually, the offer is the same. It's a timely, compassionate, needs-led support without the requirement to meet clinical thresholds. Next slide, please. So on this one, we'll talk about how Safe Havens and their staffing model. So Safe Havens are staffed by experienced, skilled teams who are confident working with people in distress in a non-clinical setting. Teams typically include senior caseworkers who provide that day-to-day leadership, oversight and decision-making, caseworkers who deliver the majority of the one-to-one support, and lived experience roles, which we've already discussed how are the really important part of the Safe Haven model. While roles are clearly defined, the way the team works is intentionally flexible. Staff respond to what the person's needs are in that moment. All staff are trained to recognise and manage risk, de-escalate distress, hold compassionate, containing conversations, and manage appropriate decisions around escalation when required. Staff are also skilled in balancing emotional support with practical problem solving, which is often key in helping reduce that distress. Crucially, Safe Haven staff are not working in isolation. They are supported by clear escalation pathways, strong leadership oversight, and close working relationships with VCSE partners and statutory services. This ensures that when additional support is needed, it can be accessed quickly and appropriately, and that the team feels supported to make safe and confident decisions. So what the support includes, the support provided in the Safe Havens is needs-led, person-centred and recovery-focused. When someone attends, whether in person or virtually, they are offered one-to-one support in a calm, welcoming environment, and the immediate focus is on helping the person feel safer, reducing distress and understanding what has brought them in that day. This often starts with emotional containment and reassurance, giving people the space to talk, feel heard and begin to settle, alongside grounding and de-escalation techniques where needed. We complete an initial assessment that focuses on understanding risk and identifying any urgent or emergency needs. Where escalation is required, staff can support onward contact with services such as NHS 111 option 2, crisis teams, ambulance services, social care, police or homelessness services. However, many people attending Safe Havens do not require clinical escalation. Instead, a larger part of support focuses on practical problem solving, recognising that practical stresses are often the main drivers of crisis. That might include helping someone think through housing issues, financial stress, food insecurity, relationship difficulties or employment concerns, and supporting them to make the calls, complete referrals or access that immediate practical help. By addressing these issues early, Safe Havens play an important role in crisis prevention and early intervention. They provide a supportive alternative to A&E or clinical crisis services where appropriate, helping people before distress escalates further and reducing the likelihood of repeat crisis presentations. We also support people to develop safety plans and RAP plans, helping them recognise triggers, identify coping strategies and plan what support to access if things start to feel overwhelming again. To help guide and evidence the impact of this work, we use such tools as a brief distress scale, goal-based outcomes, and pre- and post-intervention measures. These are used in a way that feels supportive rather than clinical and helps us understand what's changed for the person during their contact with the Safe Haven. The overall aim is to support people leave feeling less overwhelmed, more in control, and with a clear plan and onward support in place to help prevent further escalation. Safe Havens are not standalone services. They're designed to fully be integrated within the wider mental health and crisis system. The teams work closely with the NHS crisis and community mental health services, local authorities, primary care, VCSE organisations, and housing and welfare and employment services. Safe Haven staff attend MDT meetings, maintain regular contact with partners, and share learning and themes to support the system-wide improvement. A key part of our role is supporting people in ongoing support, such as Together in a Crisis, community mental health support services, NHS dawn therapies, recovery colleges, or specialist statutory and voluntary sector provisions. This integration helps ensure Safe Havens reduce pressure on statutory services, prevent repeat crisis presentations, and provide continuity rather than a single point of contact. Next slide, please. So to bring this to life, I'll briefly share a case study. So John was a 40-year-old man who attended a Safe Haven experiencing low mood and significant distress. He was homeless, had multiple social stresses and a forensic history. He had lost his flat, his possessions, including his phone, and had been unable to successfully access support. At presentation, his crisis score was a 9 out of 10. During his visit, staff provided emotional support and focused on the key driver of his distress. That was homelessness. They placed a street-link referral, contacted the homeless prevention team, worked collaboratively with the Change in Lives homeless response team, and John left the Safe Haven with a clear plan, including support to be found the following morning, access to a phone, and links into further housing and practical support. He was also supported Together in a Crisis for ongoing help. Following this intervention, John's crisis score reduced to 1 out of 10. This case really highlights how addressing practical issues alongside emotional support can rapidly reduce distress and prevent further escalation. I'll now hand over to Rebecca, who will share partner insight and reflect on safe havens from a wider perspective.
Thank you very much for having me. My name is Rebecca Ramsey. I'm a nurse consultant and I work at the psychiatric liaison team at Newcastle at the RVI and at Gateshead as well. So just to provide my insight. So when I'm thinking about what difference Safe Havens has made to my part of the system, so just as a bit of background, so liaison psychiatry is a team that works in the hospital when people present with any sort of mental health crisis or distress, or it may be that we get referrals from the wards within the hospital. We do a full biopsychosocial assessment. We're often assessing for sort of mental health requirements that would require ongoing intervention. And often people that come to the emergency department absolutely come with a physical health need. It's very few that don't. However, there are those patients that come in that sort of don't require sort of a mental health requirement and may be more suited to go to Safe Havens. So the difference that Safe Havens have made to this part of the system to sort of the emergency department is that often people present with a variety of psychosocial needs, as we've already mentioned, so risk, finances, homelessness, problems with relationships, being socially isolated, and it might not be that there's a clinical requirement for them. So we're then able to signpost onto the Safe Havens once we've done our assessment. We know as well that there's really limited resources for people. We know how stretched the system is. We know that there's a really high threshold for secondary care. We know that actually it might not even be required. We know that talking therapies might not be. So the Safe Haven offers that sort of immediate psychosocial support that we can refer the person on to. It's amazing because there's a number of ways that people can access the service, which is great and bespoke, and that gives people a variety of ways to come. What we do know is that often people do want that face-to-face human contact, and often people have already tried to ring crisis services, they might not feel that they can wait for that, and they might want to go somewhere and leave where they are, and Safe Havens are perfect for that if there isn't a obviously clinical requirement. So that's really important. It's hard to talk exactly what the impact of the flow on the ED would be, but it provides people with another option to go to if they haven't got that medical requirement or that urgent sort of mental health clinical requirement. And so it may well prevent people from going to emergency department and having a terrible experience by waiting in a very busy and often distressing environment. And I think already, as mentioned as well, if people have an alternative to go to, if they've got that immediate sort of psychosocial intervention that can be provided in person, then it might be that they don't reach that threshold for secondary care or that crisis sort of clinical requirement. So that will have an impact on the system as a whole. We know, like I said, we know that often people in crisis want that one-to-one, face-to-face, and that's how Safe Havens could sort of reduce the pressures on the emergency department if there isn't that sort of clinical requirement or medical requirement to come to the emergency department. And I think, as I've just said, patient experience, if you don't have to be in the emergency department, you haven't got that requirement, it's probably not, it's not a nice space for many people, and environmentally busy, it's the environment is very difficult. I think the Safe Havens as part of the wider system really complements what we already have in Newcastle, and it just gives that additional option for those in crisis or those that require that psychosocial support. It's fantastic because it gives, whilst I say there's a wider system, it does feel often that options are really limited for people, particularly when they're complex and they have different psychosocial requirements. And we might offer that signposting, but also for them to be able to have that emotional support immediately is really, really important, and it gives us some options when we're safety planning with patients about what could you do in the future, what, you know, if you didn't need to come to the emergency department, if there wasn't a medical requirement, what could you do, where could you go, where could you seek that help. I think the partnership working with the Safe Havens has been absolutely crucial. I think it was really important that we had a real shared understanding of what the system was, and in particular the nuances of the population that we're serving Newcastle, and what are the stresses. We know obviously there's a lot of socio-economic concern which impacts people greatly in terms of finances and accessing services, and also we have lots of people that fall through the gaps of services, don't we, that might not be accepted to one thing or another. So having that sort of understanding together of where people fit, or where we can direct people to, is really, really key. And when the services were being set up and sort of implemented, we were really included as CNTW. I had lots of meetings about what the safe haven would look like, how we would refer in, what the sort of what the criteria was, and also some reassurance about what if someone did go there and actually there was a clinical requirement, what would happen? Would that be quickly picked up by the clinicians at the safe haven? And obviously we were aware that there's very strong governance procedures there as well, so we knew that you send someone there, and if it wasn't suitable, then we know that they would get the right sort of help and support. But that was really key, and I think just having and being able to visit the safe haven, so we were able to visit, we're able to look at what the safety plans look like, and we discovered we have a lot of language in common in terms of the safety planning and some of the interventions that are offered. The impact of having safe havens to refer on to the team is remarkable, really. Sometimes when you're working within liaison psychiatry, options are really limited. If somebody's not hitting the threshold for crisis or a mental health act assessment or admission, we're thinking secondary care, but we know obviously the thresholds are really high, and there could be a long wait. And actually there's a lot of people that we see that really don't have a mental health requirement clinically, but there are lots of psychosocial stresses that are impacting on the person's well-being and about how they can access support and services. But what safe havens do is it offer clinicians a tangible option for support, a face-to-face option for support for people, which is really, really important. Whilst some people do absolutely prefer to sometimes speak online or have telephone conversations, a lot of people really find it very containing to see people face to face. I know my experience as a nurse in the emergency department, often there wasn't a clinical requirement, but actually having that emotional support to be able to talk about your distress, to be able to talk about what's going on is really, really crucial. So it offers clinicians here something tangible to signpost people to, if they require it, for the future as well. And it gives us that, you can go there now if you want, or you can access that in the future, which is really, really important, because often a lot of services that we refer to, there's going to be a bit of a wait. It might be a bit of a, we might put a referral in, but you might not be accepted. There's all of that type of stuff, isn't there? But it's that sort of for the clinician, having that tangible offer to somebody is really, really important, and more likely that people will take up that offer as well. I think that was most of what I my sort of experiences, insight from a liaison psychiatry point of view, but they've been invaluable to our team, and we have we'll still meet up if there's any teething problems or if there's any concerns, and it's just a wonderful resource for the people of Newcastle to have, as well as all the other things that we've got. It's a great resource, so thank you. And I'd like to now hand back to my colleague Sam Katula, who's going to talk a little bit more about the learning from the safe havens.
Thanks so much, Rebecca, and thank you for sharing that. So yes, some of our learning. So since the development of the first safe haven, there's been a lot of learning. A lot of that learning has been used in the development of the safe havens that followed up after that. We have tried to capture some of the key things that we found really, really helpful. So the first of that is the integration with a wider system. I know my colleagues have spoken about that and how central that is to the success of this, but that attendance at MDT meetings, linking in with system partners has been really, really important in making sure that the support aligns with partners and continuity, and making sure that the support we're offering aligns to the wider support that people are receiving. Referral processes, we've had a varying referral routes initially. So a new Newcastle Safe Haven initially went live as professional only, and Northumberland and North Tyneside went out as open access. We've been able to review this and see what people find most beneficial, and been able to tailor that and support that to make sure that it fits the needs of people. We've also been able to make sure that the referral forms are embedded into partner systems for ease of referrals, so they don't have to go through long processes to complete the referrals. So, for example, the Safe Haven referral form is embedded into the North East Ambulance Service system, as well as primary care, so that they can do it directly from that. We have regional meetings. So part of the regional meetings we use to share data, to share themes, to share intelligence, build stronger relationships, and continue to work on where there's areas of improvement across the board. We have been able to seek and source additional funding to support the service. So a local council has supported one of our safe havens to support with the homeless, and been able to then provide a tangible support to the people who come in with those housing needs that James touched on earlier, that we see quite often. We've also worked in partnership with local food banks on the provision of regular supply of essential food items, meals, food parcels, and also working towards becoming a drop-off and pick-up point for meals. Again, worked with supermarkets to offer essential provision for people, which we see regularly. We also attend monthly and quarterly meetings to review all areas of the safe havens and work collaboratively to achieve outcomes. And again, that community integration and working with urgent and emergency services, local authorities, VCSEs, and the community as well, to be central within the support we provide. Slide, please. So we have noticed a lot that it takes a long time for the safe havens to be embedded with communities, especially if there's not been a safe haven in that area before, if it's new, or if the local areas surrounding it don't have a safe haven. So this is a bit of information on our Northumberland Safe Haven, which went live April 2024. So that's the first year of the Safe Haven going live. As you can see there, initially had 27 people coming in, but gradually that has really increased, and we see a lot of people regularly, a lot of contacts, and this is just the people that attended in person as well. I know in the past 12 months, we've seen over 2,300 people in that safe haven alone. Again, similarly with referral source, we have the option of a professional referral, people being signposted or self-referring, but we can see across the board that people do tend to self-refer and attend themselves. But we see quite a varying age range and quite a varying split between male and female attendees in our safe haven. So in terms of financial impact, we continue to see that our safe havens really bring value. I think it's really important to highlight that the data we are using here for comparison is from the NHS average unit cost data, and we calculate our unit costs by dividing annual sum of the contract and the people who visited in the year. It's also really important to highlight the value of these models isn't just the cost within the service itself, but actually what it prevents later down in the system, and also the social value brought by these models. If you came to our last webinar, you will have heard Cassidy talk a lot about this, and we see it, and it's huge. And we hear that people feel heard and people feel seen and people feel able to get support when they need it in the way that they need it, and are able to progress and move on with their lives. So I've just got some of that cost data on there, and we've also added on the comparisons with crisis team, psychiatric liaison team, and the unit cost data for walk-in assessment unit service. Slide, please. Yeah, so just to summarise some of the key takeaways and what we've learned in setting up safe havens is how important that early engagement and partnership buy-in is. That is both with the community, but also with our system partners being involved in the design and the development, coming to see the safe haven, going to meetings, having those ongoing conversations to really have a strong relationship from the start, and continuing to have that strong relationship throughout, even after the safe havens go live. I know Northumberland have the local neighbourhood police team who come in, drop in regularly and offer support for people who have any difficulties in their communities that they wouldn't feel comfortable seeing a police officer in their community, for example. So a lot of our partners continue to support and work into the safe haven, and that really comes from that early engagement and the partnership buy-in. Got really strong clinical infrastructure to support our frontline teams. There's a lot of complexity. Obviously, it's a drop-in service. We see a lot of risk, and it's really important for our frontline teams to feel able to support people appropriately and manage that, and also really important for our partners to have the confidence that we're able to do that and do that appropriately. We've touched a bit on the partnership working from the design stage, system integration, MDTs and shared systems, and it's really complex to have shared systems, and we know that and we understand that, and we still have some of those challenges in some of our areas. But we have seen, for example, in North Cumbria, where we do have a shared system with our partners, the difference that makes, and how helpful that has been. We will have a session on that shared system and the development of that shared system and the challenges. So please keep an eye out on that. And we've spoken about the lived experience as well and the clarity of these roles. So it's really important for us to have lived experience, but also the clarity of how these roles differ and the value that these roles bring is really, really important. Again, there's strong community links and partnerships, and the continuous review of the models. So not just stopping when the service goes live, but actually continuously having the focus groups, the questionnaires, feedback from the people who use the service, our partners, and creating this space to be able to get this feedback and continuously evaluate the service has been really important, and has allowed us to get lots of ideas on how we can move forward and improve what we've already got. So yes, just before I hand back to Emily, there is a poem by somebody who has used our service. It was handwritten by a person who used the safe haven, who wrote it and decorated it and brought it into the service, where it's now a very much loved feature of the welcome space. So, thank you.
Thank you, Sam, and thank you so much to all our presenters. I'm sure you'll all agree it's really good to get various different perspectives from the team that operationally deliver our safe havens, but also our amazing partners that we work with, just so you can get that perspective on the impact this is having, most importantly for the people that we're seeing coming through the door in the safe havens, but also on the wider system. We've got quite a lot of questions, which is fantastic, in our meeting chat. So we will do our best to get through as many of them as we can. If there's any that we run out of time for, we promise we will follow up with you directly afterwards. And as always, we're really happy to have any other kind of follow-up conversations. If you're interested in what a safe haven could look like in your area, we'd be really happy to have follow-up discussions about that as well. But let's get into the Q&A, and we'll get through as many as we can. The first couple are quite operational, so I'm going to ask Jack and James if you wouldn't mind coming back on camera and off mute, and we'll try and just work through as many of these kind of quite operational questions as we can. And again, if we haven't got the specific information now, we can certainly follow up. So Jack and James, there's some questions around the percentage of people that we see and the mix of people that we see in person, online or by telephone. If you've got that, any information on how we overcame kind of digital records, GDPR issues. We obviously have DPIAs in place for all of our services, and we're on the Great North Care record, but anything that you want to, you think would be helpful to share there. And then also about how we engage with diverse communities, so thinking about communications, disabilities, etc. If we can start with those first three, and then we'll come into some more, that would be great.
Yeah, of course. In terms of the percentage of people that we see in person, online, and via telephone, it differs by geographical location. So with Newcastle as an example, we might see a high use of virtual appointments because of maybe a more support available in that area as an example. But within Northumberland, we see a higher footfall of people walking through the door. So more than 60% of our people accessing the service in Northumberland as a comparator would be in person. So yeah, it differs by area. In terms of the digital records, GDPR, etc., we worked very closely with all providers that we work with on the data sharing agreements. It is one of the more difficult hurdles to overcome, I guess, through this process. But yeah, we got there. And in our safe haven in Cumbria, we do have a shared system where all partners use a shared system in that area as well.
Lovely. And Jack, what about engaging with diverse communities? And do you want to comment on the next question as well from Judith, which is around people who are in housing and financial difficulties? How do we ensure that the onward support has the capacity to help with that as well?
Yeah, no worries. So in terms of engaging with diverse communities and communication and disabilities, we obviously approach engagement in different ways. So we spoke about the accessibility and communication perspective. We've got in-person, virtual, phone call appointments. Staff adapt the communication style based on the need. Some people we have supported with email support and text support because that was a better way for them to receive that. We support people with sensory needs, learning disabilities and neurodiversity by slowing things down and being flexible to kind of what they need. In terms of community engagement, we work closely with all the local VCSE organisations who've already have that trusted relationship with the diverse communities, and we use community partners to help shape and message and everything and improve everything we do and kind of our reach. We also work with interpreters to kind of be able to access support for people who might not have English as the first language. In terms of the question around the housing difficulties and how we support the onward referral, we work closely, obviously in North Tyneside, I'm speaking here in Safe Haven as a whole, we work closely with the local housing teams, the homelessness services and the VC partners and understand their capacity and at what level they're at and be able to support with. And that helps us give the client service user a more realistic approach of when support will be available. We're also very clear and honest with the people of what the services can and can't offer, so the expectations are realistic for the client. And our role is really just to reduce that immediate distress while they're kind of waiting for the more specific service to be able to support with.
Thanks, Jack. I think that place-based working with other small grassroots VCSE organisations, other kind of partners, we do a lot of work with the police, don't we, in all of our safe haven areas. So that kind of working is so important, isn't it, for our local teams? Jack, there's a couple of questions on kind of risk assessment and how that works. So got a question from Beth, and then a little bit further down in the chat, a question from Helen. So I'll read Helen's first. You spoke about the completion of a screening assessment when individual attends that they complete or you do with them. How is this received by patients and carers in distress? Can you speak a little bit more about what this entails? Any challenges, outcomes, if this is difficult in times of crisis and distress? And Beth asked a kind of similar question. How do you ensure, thinking about safety, how do you ensure safety for other service users in the building and staff in terms of the risk assessment process?
Yeah, there is. So in terms of the assessments and how it's how it's really met, we've had no issues really around this, but I get the kind of where the questions come from. We just frame it as more of a collaborative conversation rather than that assessment. It's not a formal, it's not a clinical assessment, and it's framed as a way to help them feel safer, they're in a calm environment, and they have control over the situation. Obviously, the main challenge when someone's extremely distressed is that they might not feel that they want to be able to pass a kind of complete this from there and then. So the staff will just slow things right down, prioritize that emotional containment, and revisit the parts of the conversations once the client and service user feels comfortable. In terms of capacity, we do have capacity considerations, but they're managed more dynamically rather than through any kind of restriction. So we don't operate on a first come, first served basis. It would be staff are constantly assessing the number of people in the building, the level of distress being presented, and the staffing levels at that time. If it becomes busy, we just prioritise the need and the risk at that time and be transparent with the people about the waiting times and any alternative options. And maybe that we kind of book an appointment to come back at a later time, or after we've kind of done that dynamic risk assessment there and then of their needs and their safety. And obviously around client safety as well, the support provided is one-on-one, so it's not a group setting. So that's how we manage the service user risk to other clients in the building.
Brilliant, thank you, Jack. And then there's a question around kind of national, regional services. Is there any geographical criteria? These are very place-based local services, aren't they? But is there any kind of particular criteria that we have around that?
No, so in the northeast, so in Newcastle, Northumberland and North Tyneside Safe Havens, you don't have to be from the area to use the service. You could be holidaying, visiting a friend, working, passing through, visiting the area. If you're in the area and need support there and then, you're very welcome to come through the door and receive that support.
Brilliant, thank you. Conscious of time, so let's see if we can get through a few more. Philip, you asked a question in terms of the NHS capital funding that's being rolled out over the next 4 years. Everyturn, we're members of NHS Alliance and the Association for Mental Health Providers, so we're all often asked to kind of feed in learning from our models through those membership organisations. I'm not personally aware of being asked to feed into the kind of the programme that you're speaking about. We are always very happy to share our learning, though. This is kind of part of us as a non-for-profit organisation, kind of sharing our learning today, but please feel free to get in touch directly if you think it would be helpful for us to share any information. There is a question, I think, a little bit further down for Rebecca, if you wouldn't mind, Rebecca. A question from Hannah asking, did you experience concerns from clinical system partners and how did you overcome these?
No, not really. I think we were quite welcoming because it's just another fantastic resource to have for people. I suppose the concerns are, as I mentioned, just knowing what the criteria was and what the escalation would be, you know, in case somebody did present and then, you know, there was a higher level of need or a clinical requirement, that we could sort of be assured that then they would get the right sort of help and support. And I suppose how we've overcome that is to just have those conversations with Everyturn and you know, and know what their governance procedures are, so that staff, that they've always got access to senior support, they can escalate matters as required. But no, I think it's just having a really clear idea about what the criteria is for clinicians. So clinicians from, so for example, from our team, were, you know, had the opportunity to go to the Safe Haven, to visit, to see what was actually being done there, to see what type of referrals would be appropriate. So we were able to sort of know that. We know what the safety plan would look like, what the documentation looks like, so we can sort of have an idea of who would be appropriate to signpost to the Safe Haven if required. And I suppose it's just about those ongoing conversations. I suppose at the start there was some concern about how can you directly signpost someone from the emergency department to a Safe Haven without having done that mental health risk assessment, and we decided that wasn't really, you know, we couldn't really do that, because that's a lot for the nurse on triage to just be like, well, so, and that hasn't really come up as a as a problem, because everyone would have that sort of assessment from us if it was clinically required. And often there is a requirement for people to be here, but it is something that we can signpost people to in the future. So I suppose it was just everybody having a really clear idea of what the criteria was, you know, what the governance procedures were within Everyturn to be assured that people would get what they needed, you know, because people are complex and they change, and we might not be aware of everything. So it's just to make sure that we had all of that information, and then those ongoing conversations. We've had this situation. What do you think? How can we learn from it? What can we do? And having really clear lines of communication, and then just all staff sort of having that opportunity to know what the safe haven looks like and who goes there and what it looks like has been really helpful for that.
Fantastic. Thank you, Rebecca.
Thank
That's
you.
really, really helpful. I'm really conscious of time, so we're going to have to wrap up in a second. I'll just try and quickly answer a couple. So there's a question around hospitality beds. Our Hope Haven partnership model that we're talking about at our webinar on Thursday, there are some short stay beds as part of that model. We also did a webinar as part of our first series on our crisis accommodation services, so do feel free to go back and have a look at the recording for that. There's some information there. What do we think about the new mental health emergency centres in conjunction with the safe havens? I think it's really interesting. It's going to be really interesting to see the development of these models. I think we've got a colleague or two from Mental Health Matters on this webinar. Mental Health Matters have got an amazing safe haven model co-located in emergency departments, so do feel free to have a look at what they're doing. But I think just having a look at the impact and how these models are going to work, hopefully really collaboratively, where we're bringing support into the community, but also kind of meeting people wherever they are, is going to be really interesting to see how that develops. We absolutely want to be part of the development of the mental health hubs within neighbourhoods, and I think it's really important that mental health is really at the kind of forefront and integrated into the new neighbourhood models as they're developing. I think that's all we've got time for, really sadly, in terms of your questions. If we didn't get to one of your questions, apologies. We will follow up, we promise, afterwards, so you can you can get a response to your question if it's not been answered. But thank you so much for your engagement during today's session. Thank you again to all of our speakers. As I said, we've got our Hope Haven webinar this Thursday at 1 o'clock, so do check that one out. You can also go back, like I said, and have a look at our previous recordings from the webinars in Series 1 and the earlier ones in Series 2. And we'll also have a brand new series coming later on in the summer, all around analog to digital. So look out for more information about that. But we will wrap up. And again, huge thanks for joining us today, and we'll speak to you soon.